in hematology, Special Coag Lab Hemophilia Center, and he also is a member of our core consultative hematology or so-called benign hematology group. But it's not benign, Chris, right?
That is correct. It is not benign. Thank you, Dr. Nichols, and good morning, everyone. We're going to talk over the next few minutes about a complex series of disorders which are very challenging to clinicians and to laboratorians in terms of diagnosis and treatment, and that is the thrombotic microangiopathies. I do want to share that my slides will be on the app later, but there's a coming publication in next year in the Mayo Clinic Proceedings, which is going to encompass all of the comments that I'm making here. And so you may want to look forward to that, which will also include a lot more information than I'm able to share with you this morning. So we're going to share with you what we have been developing in our practice as an algorithmic approach to treating this complex series of different disorders. And the challenge that we face is that the thrombotic microangiopathies are a very heterogeneous set of problems. They certainly begin with the presentation of hemolytic anemia and thrombocytopenia, may have at presentation already evidence of organ damage. But aside from MAHA and that, they have a common pathway of microvascular thrombosis. The pathophysiology may be from a combination of endothelial damage and coagulation, but the actual pathogenesis can be quite varied. And as anti-complement therapy with eculizumab began to be reported, it became essential for us as clinicians to try to determine if there was a complement dysregulation problem as part of the pathogenesis or where there were other possibilities. Was this routine TTP and other things of that nature? And when you consider that eculizumab has a cost of $500,000 to $700,000 a year for continued use, it becomes a very important question in terms of cost-effective therapy, but also making sure that patients actually need the interventions that we are recommending or tempted to consider in their treatment. And so we convened a multidisciplinary group in September of 2014 that represented a variety of different disciplines, including pediatric colleagues and our bone marrow transplant colleagues. And I want to certainly acknowledge the hard work of my colleagues in doing this. In January of this year, we had developed a basic set of care pathways. When you see CP on the coming slides, that's representing one of the care pathways that we have developed. And receive feedback from the other members of our practices. And since the late summer of this year, we have been translating that into the publication I just mentioned a moment ago. When to suspect? Well, essentially common criteria. We are looking for the presence of microangiopathic hemolytic anemia with reticulocytosis and signs of the ashes of hemolysis, increased LDH, indirect bilirubin, urine hemosiderin, and so on, and the presence of schistocytosis by common criteria greater than 1% schistocytes on the smear constitutes significant schistocytosis. Coupled with thrombocytopenia, many times the thrombocytopenia may be fairly moderate, 50,000 or so, occasionally getting down into the more severe range. Different bone marrow transplant groups have been working on their own criteria, which are referenced in the paper and on some of the other slides. Other signs and symptoms that patients may present with showing end organ effects include nausea, vomiting, bloody diarrhea, neurological symptoms, renal insufficiency or failure, a complex urinary sediment or proteinuria, and in some fever, though fever is not always present and maybe less than 50% of the time. So we believe that when there is TMA present, it is important for the clinician to step back and include, at least in their mind, the broad differential diagnosis of possibilities and begin to exclude those methodically. Certainly, Shiga toxin with the bloody diarrhea and so on is as much, a clinical suspicion that can be confirmed by stool studies. But the approach there would be very different than perhaps TTP or a true complement dysregulation problem. Other precipitating factors that need to be looked at the time of presentation is the patient receiving medications that can produce these phenomenon. Do they have an infection that is producing DIC? Are they a transplant patient? Do they carry a rheumatological diagnosis? Do they have a malignancy, or are they pregnant? All important factors to consider at the beginning. Roughly, the breakdown will be once Shiga toxin-induced TMA is excluded on clinical grounds, about 25% will have TTP, 20% will have complement dysregulation, and then 55% are from the other known potential inciting factors. Among the drug-induced, we have those that produce endothelial damage through immune mediation, classically quinine or oxaliplatin, or we can have direct toxicity such as tacrolimus or gemcitabine. In a recent review by Reese, quinine was actually the most common inducer of drug-induced TMA. Then, after the history has been taken into consideration, we recommend a tiered approach to our testing. The level 1 tests shown here include Adams TS13 testing, a complement panel, which I will mention in a moment, as well as looking for this ashes of hemolysis as mentioned. We do talk about doing a homocysteine, particularly in the pediatric population, to make sure that a cobalamin A deficiency is excluded. It's also recommended to save at least 15 cc's of a frozen specimen for future testing as may be indicated. If there's the diarrhea, certainly doing PCR for Shiga toxin can be done, and if there is concern about a autoimmune disorder beginning with an ANA screen can be mentioned. And so here again are our level 1 tests. Spending a few moments speaking about Adams 13 specifically, with a number of groups assessing levels with this. Usually a level of 10% or less is considered specific for classical TTP with about a 90% specificity. It's important to remember, however, that individuals with levels above that 10% may still have TTP and benefit from plasma exchange. And so clinical judgment is always necessary here. However, if you have that classic presentation, that should help to reassure us that we may not need to spend thousands of dollars on DNA testing for complement mutations. The Adams 13 test itself is performed by fluorescence resonance energy transfer methodology using a recombinant non-denatured von Willebrand fragment that contains the Adams cleavage site. At the cleavage site, this is paired with a molecule that covalently attaches that includes both a fluorescent donor and a quencher molecule. Uncleaved, the fluorescence is completely quenched, whereas with cleaved, it releases the fluorescent signal. What's important to remember about this test is that there can be clinical features that can lead to a misinterpretation. For instance, bilirubin can quench the fluorescent release and lead to falsely low levels. And here's just some examples using our American way of reporting bilirubin in terms of the degree of Adams 13 level quenching that may occur. If the degree of hemoglobinemia is sufficient to discolor the plasma, that can also lead to a falsely low Adams level. If the specimen is not properly handled and left sitting in a room temperature environment for a period of time, leukocyte activation can occur, which can lead to falsely elevated levels of Adams 13. So these are just some caveats in the interpretation. If we find the levels low, we move to an inhibitor screen to try to determine if we're dealing with a neutralizing inhibitor assessed by classic Bethesda methodology or a clearing inhibitor, which is done by Western blot or ELISA titering. It's important to only do the Adams testing in appropriate circumstances where there's a real clinical indication, because low-level antibodies like this can be seen in 3% of healthy patients and 15% of patients with SLE, yet in the absence of thrombotic microangiopathy. And we can move to our level 3 test in certain circumstances, particularly in pediatric populations. If the Adams level is less than 10% and there is no antibody present, then we could certainly consider Upshaw-Schulman syndrome and look for a mutation that is present, a congenital mutation. As far as what we include in our complement panel, which is now available as a panel through our laboratory, we recommend classic pathway and alternative pathway functional studies, the CH50 and AH50, then measurement of C3 for fragment, the MAC, or final terminal attack complex, factor B fragment, and factor H. Again, an important point here is to try to freeze the specimen to less than 70 degrees centigrade within 30 minutes of blood draw to stop complement activation in vitro, lest there be abnormalities occur just because of that factor alone. This is again, this will be best appreciated, but what do we expect among that complement panel if our TMA is complement mediated? We should see potentially a low CH50, a low AH50, normal levels of factor 4 and 4 fragment. C, though involved in alternative complement activation, remains normal simply because it's the most abundant complement factor in the body, and it often may take a lot of consumption before the level is rendered low. MAC should be high. B fragment may be high. Factor H often is low in these circumstances, and factor I may be low or normal. Our level 2 tests would move on to doing the complement mutation studies. Here of the basic effectors of anticoagulation that result in a loss of function, such as factor H and factor I, and then factor B and C3 would be a gain of function activity, and the CFHR 1, 3, 4, and 5 would indicate an increased tendency to developing complement autoantibody. The Coagulation protein mutations for plasminogen, thrombomodulin, and so on, again, usually are going to arise in the pediatric population. Is a tissue biopsy necessary? And we often think that it is not required. The kidney biopsy is usually the most helpful, but here to rule out other causes of acute renal failure. Even in the case of AHUS, the immunofluorescence for C3 may be negative. Fibrinogen may be present within the capillaries in classic TTP. The patients may have a platelet-rich thrombus versus in the complement-mediated TMAs, they may have a fibrin-rich thrombi, but this is not something that can be universally counted upon. And in this situation, in the context of renal transplantation, it's important to use the biopsy to exclude rejection. The other level 3 tests include, again, the Adams 13 mutation is mentioned. We also consider a disorder that typically presents in the pediatric population that leads to aberrant protein kinase C activity, the DGKE mutation among those that can be considered. And here is just our care pathway number 9 showing this. Important to recognize these mutations, however, because the typical treatment is plasma infusion or PLEX. So once we've done our initial studies, the level 1 test, taken our history, then it's reasonable to start PLEX if the etiology is uncertain. Certainly if we've leveled things down to TTP, I'll share with you that care pathway in a moment. Shiga toxin-induced disease is best treated with supportive care only, despite some of the initial reports from the West German outbreak in 2011 that there may have been benefit from plasma exchange or from eculizumab. Retrospective reviews have shown that patients who received best supportive care did not do inferiorly to those who received the other more aggressive interventions. So supportive care is typically what we would recommend. And again, for the pediatric population, consideration of additional testing. For obvious precipitating factors, I'll defer a slide or two to our care pathway for that. Again, I mentioned that cobalamin C deficiency may lead to significantly elevated homocysteine levels, again, more often seen in a pediatric population, though occasionally can occur rarely in some young adults. Our TTP pathway at this point, of course, begins with the hallmark of plasma exchange, monitoring daily hemoglobin, platelet, and LDH levels. Based upon 1C level evidence, the addition of prednisone may be helpful if we don't have a congenital type of a TTP or Upshaw-Schulman syndrome. We plasma exchange until the platelets are greater than 150,000 for 2 consecutive days. Ideally, you might see a normalization of LDH, but that may lag actually a few days, and so that shouldn't be the thing that completely holds you up. If the patient's platelet count has returned to normal and they are staying stable, then PLEX can be considered stopping at that point. Our group stops PLEX outright. I know there is some controversy of whether plasma exchange should be tapered off, but we feel that there's no evidence that clearly supports the need for tapering. If there is no response after 7 days, then starting a course of rituximab would be recommended, again with 1C level evidence. If no response after several doses of rituximab, increasing the plasma exchange to twice daily, and if no response and you haven't been using cryopore plasma, that could be considered. If we're dealing with the general precipitating factors, our care pathway number 4 If we're dealing with drugs that are a problem, try to discontinue or substitute those with others that would be less potentially problematic. In the case of infection, treat the infection, provide supportive care. Again, clinical judgment is always necessary in these situations about whether to engage in more aggressive therapy with plasma exchange, but typically this should be sufficient. In pregnancy, challenging situation, the question is whether the baby can be safely delivered at this point. But given the fact that up to between 24 and 66, depending upon the port one reads, of pregnancy-related TTP have been subsequently found to have a congenital deletion of Adams 13 or other complement-mediated problems. This is an area where testing at that level may be very helpful in determining a subsequent approach. We'll spend a few comments in a moment on the transplant population, and again, with other underlying conditions, best to try to treat the direct problem itself. If there's probable complement dysregulation, we move to our level 2 tests, initially using plasma exchange. If we've identified a complement mutation, we move to our care pathway number 8, which is essentially changing the plasma exchange to eculizumab. If there is an anti-factor H antibody, then we continue the plasma exchange approach. If no mutation or antibody is identified, then it may be safest to stop the plasma exchange if they're not responding and switch to eculizumab. Among the renal transplant population, again, biopsy is important to discern if rejection is present, in which case the response would be to increase immunosuppression. But if there is no rejection, we go back to care pathway number 1. The stem cell transplant population, TMA may occur about 12.7% in adult patients and up to 39% in children who have had stem cell transplants. We think that proceeding to the level 2 tests is a reasonable thing to do in this context to make sure that we are not dealing with complement mediation. However, if there's obvious acute GVHD, increasing the immunosuppression would be appropriate. In VOD, the use of difibrotide has been found to be very helpful in treating this particular form of TMA. If there's been no contributory cause, I found, or refractory to other interventions, then approaching this as a TTP is our recommendation. And then again, if there are other causes, we would treat those specifically. Just a comment that sometimes if it is drug-related in this population, mycophenolate, mofetil, steroids, and ATG can replace cyclosporin, tacrolimus, and sirolimus if we're concerned about drug mediation. As evidence is evolving, if we can prove that there is indeed a complement mutation present, the current state would suggest stopping Plex and moving to eculizumab. The problem we have here is that there is no good data or consensus on how long treatment must continue. And this, of course, remains a challenge. Some patients treated up to 2 years who have had their eculizumab discontinued have had relapses. And so this is obviously an area of continued need of investigation. So in summary, we would simply recommend that if you are confronted with a case of TMA, the first thing to do is to step back and to consider the broad differential of possibilities contributing to that and eliminate them so that you don't potentially miss a contributing factor, and then to approach your testing in a methodical, tiered approach as we have recommended here. And I have to acknowledge, just in my own practice, that there are still patients that will slip through some of these criteria. Patients with TMAs don't tend to follow algorithms. And even when you are convinced that someone has a complement-mediated problem, if you give them a little bit more plex, sometimes they will resolve without having to implement eculizumab. So I'll just end by saying there's more to come in this particular area of diseases, and I thank you very much for your time.